Morning everyone. On behalf of the Department of Physical Medicine and Rehabilitation, I welcome you all for this week's combined clinical talk. We are presenting a case of 26-year-old male with bilateral shin pain that will be presented by Dr. Meghna Khatri. Now I'll briefly introduce about what is physical medicine and rehabilitation. It is a branch of medicine emphasizing on prevention, diagnosis and treatment of disorder, particularly related to bone, muscles and nerve that may produce temporary or permanent impairment. In other words, rehabilitation physician are nerve, muscle and bone expert. Physical rehabilitation is a process of transforming a person with functional limitation to a person with maximal ability through the application of medical treatment, therapy and adaptive equipment. PMR is one of the most comprehensive and multifaceted mode of treatment where focus is on patient rather than on disease. Physical medicine rehabilitation, PMR can also be described as medical specialty that employs all available modes of treatment like medication, physical agents, minimally invasive intervention procedures, minor surgical procedures like soft tissue release surgeries. It complements almost all the clinical department. There are few future trends including musculoskeletal ultrasound, intervention therapy, gait, robotic, virtual reality system, robotic rehabilitation that are coming up in future. That is our department comprising of 2 professors, 1 assistant professor and 4 residents. It was started in year 2022. Mahatma Gandhi Medical College is the first medical college in private sector in Rajasthan to start MD in physical medicine rehabilitation. We have started MD in physical medicine rehabilitation and PhD in PMR. Our daily OPD currently is of 15 to 25 patients that includes OPD patients and minor clinical procedures. These few special facilities that are present in our department. First one is gait lab that we'll elaborate in detail in next few slides. Second is shockwave therapy. We have 2 specialized divisions, occupational therapy and physiotherapy. We have some special equipment related to musculoskeletal and neurological rehabilitation. Those are unwing harness system, combination therapy and theramobility trainer. And these are few of the parts like clinical procedure rooms, seminar rooms and gait therapy, parallel bars. We are routinely performing synovial fluid replacement therapy like lubricant injection. We are regularly advising assistive devices, orthosis and prosthesis and dealing with common sports injuries. We are doing Botox procedure for dystonia and spasticity and prolotherapy as a regenerative therapy and PRP therapy also. Also we are routinely doing corrective cast for cerebral palsy and clubfoot treatment. These are few of the eminent personalities, sports person who have undergone gait assessment in our department. First one is Yash Thakur. He is a Lucknow Super Giants player and Nagpur Ranji team fast bowler. He represented India in under 19 also. Second one is Athar Taide. He is Kings 11 Punjab opening batsman and also playing for Nagpur Ranji team. Third one is Tarani Shah. He is basically Odisha fast bowler. Now I will request Meghna Khatri to start with case presentation for today.
Good morning, respected dignitaries, teachers, seniors and my colleagues. I, Dr. Meghna Khatri, first year resident at the Department of Physical Medicine and Rehabilitation, will be presenting our case for today's CCR. And our case is of a 26-year-old male cricketer that presented to us with complaints of pain in bilateral shin, which was more on the right side, with swelling on right shin for 6 months. Also difficulty in his sports activities for the same duration. We have taken informed consent from our patient to share his video following examination details and along with investigations. He is a right arm fast bowler who is regularly involved in high impact activities like running and jumping. Our patient, a 26-year-old active sports person, was apparently well until 6 months ago. when he started to develop pain in bilateral shin, which was more on the right side. Pain was insidious in onset, progressive in nature. It was of sharp character and on his medial lower leg, which intensified with prolonged walking or running short distances and was relieved at rest. There was no radiation or diurnal variation in pain. His pain was reduced with non-weight bearing, but a steady ache was always present. He also developed a swelling in the right middle third of shin that started spontaneously along with pain and gradually progressed for a few days and became persistent and localized to the site of origin, roughly of a size of a lemon. He tried using compression stockings which helped in reducing swelling, but pain still persisted. The symptoms were thought to have started shortly after starting his sports activities, and being a fast bowler initially, he was able to bowl 2 overs without pain. Later he started feeling pain even at the onset of his bowling action. The patient was referred to the impaneled hospital with BCCI and National Cricket Academy, Bangalore, where he was advised to rest for 8 weeks. His condition still was not improving after rest, and he played Ranji final and full IPL season in the month of May-June, during which his symptoms aggravated substantially. Immediately after IPL, due to pain, he rushed back to the National Cricket Academy, Bangalore, where after MRI and X-ray, he was again just advised rest. Patient came to Mahatma Gandhi Hospital, Jaipur, and the Department of Physical Medicine and Rehabilitation in the month of June with complaints of pain in bilateral shin, which was more on right side, and swelling on right shin that had progressed over the course of few months. Pain was sharp on routine work, which was not relieved on rest, and however there was some relief from analgesics. Intensity of pain on numerical rating scale of pain was recorded to be 6, and there was no history of fall, fever, fatigue, tingling sensation, or numbness in lower limb. Our patient is an old case of hypothyroidism and has been on medication tablet L-toxin 50 micrograms since last 4 years. There was no history of any other lifestyle or metabolic diseases, and there was no past history of any major trauma or surgery. There was no significant relevant family history, and patient does not have any allergies to specific foods or drugs. There is no history of smoking, tobacco chewing, or alcohol consumption, and he had normal bowel and bladder habits. However, pain had started affecting his routine exercises and sports-related activity. Till now, we have a case of a 26-year-old male with bilateral shin pain, which was more on the right side, with swelling on right leg since 6 months. At first, the pain was during exertional activities like running that usually got better after the training session. Later, the pain was even felt at walking with minimal exertional activities. Can the audience think of possible differential diagnosis in our case? Anybody? Okay. So our causes could be soft tissue causes, bone. Yes, sir.
You said that there is no history of trauma,
Yes, sir.
but he is a sports person. So it is possible that there may have been a trauma which he might have kind of forgotten, because it is very frequent for them to have injuries, and usually they don't pay much attention to it or they don't remember it. So you have to keep that in mind. Only point against is that it is bilateral. Trauma is very unlikely to be bilateral at the same place.
Yes, sir. So when I speak about trauma, I speak about the major trauma and not micro traumas, which will be discussed later in our slides. So it could be due to soft tissue causes, bony causes, metabolic causes, neurovascular causes, inflammatory and infective causes, and malignant causes. For soft tissue causes, it could be a simple muscle strain, anterior tibialis muscle strain, because of the site of the pain. Tendinopathies like anterior tibial tendinopathy, chronic exertional compartment syndrome of anterior compartment of leg, depending on the site of pain and character. Bone causes like anterior tibial stress syndrome, medial tibial stress syndrome, also commonly known as shin splints, very commonly seen in sports people, or stress fracture due to bone stress injury. Metabolic causes like osteomalacia, vitamin D deficiencies, micronutrient deficiencies like calcium, magnesium, and phosphorus that can cause bone pain. Now, neurovascular causes like peripheral neuropathy or peripheral artery disease, nerve entrapment syndrome, tibial nerve entrapment depending on the site of pain again, and artery entrapment syndrome, anterior tibial artery entrapment commonly. Inflammatory, it could be periostitis, and for infective causes, it could be osteomyelitis. For malignant causes, we have kept osteosarcoma and Ewing sarcoma as our differentials because of the site and character of pain. Now, on general examination, our patient was conscious, oriented. His pulse was 65 beats per minute, normovolemic, normorhythmic in nature. His blood pressure was recorded to be 122 by 74 millimeters of mercury, and respiratory rate to be 16 breaths per minute. He was afebrile during the examination. His height was recorded to be 177 centimeter, Weight was 74 kgs and BMI to be 23.62 kg per meter square, which was under normal for his age. On general examination, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema in our patient. His central nervous system, cardiovascular system, respiratory system and para-abdominal were all under normal limits. Neck examination did not reveal any enlarged thyroid gland. On inspection of local examination of bilateral lower limb, both legs appear equal in size and symmetrical. A swelling was noted on the right chin from below knee to mid-leg. There was no redness, bruising, abrasion or any other discoloration over swelling with no engorged veins. The swelling was not moving while walking or running and it was a non-pulsatile kind of swelling. On palpation of lower limb, the temperature over skin was not raised. There was tenderness over anteromedial region of right tibia and mild tenderness over left shin. Muscle bulk was equal on both sides. Peripheral pulses like femoral artery, popliteal, posterior tibial and dorsalis pedis artery were palpable bilaterally. A 3 into 3 centimeter swelling over anteromedial region of tibia was present on right leg. The swelling was soft in consistency and it was not fixed to skin, non-pulsatile, non-transilluminating and there were no lymph nodes enlarged bilaterally. On further musculoskeletal examination of bilateral lower limb, tone, bulk, sensory, motor was normal bilaterally and deep tendon reflexes were present on both sides. For further musculoskeletal examination, we examined for different muscle groups. So we examined for adductors, hamstrings and calf, which are the main reason for causing pain at shin area or any other leg pain. For adductors, we did adductor squeeze test. In this, we asked the patient to lie in supine position with knees bent and feet flat on the floor. Then we place a ball between both knees and ask them to squeeze their knees together as hard as they can for about 5 seconds. The test is positive if they experience pain in the adductor muscles or the anterior medial pelvic ring, which was present in our patient bilaterally, however more on the right side. For hamstrings, we did 90 by 90 straight leg raise test with the patient lying in supine position with both hips and knees bent at 90 degrees. Then we extend one knee as far as possible while keeping the other leg in the starting position. If they cannot extend the knee beyond 20 degrees of full extension, it indicates tight hamstring, which was bilaterally present in our patient. For calf tightness, we did toe point test. In this, we asked the patient to sit with legs straight out in front and pull the foot back towards them. If toes points towards the ceiling, it indicates tight calves, and it was bilaterally present in our patient. On examination of range of motion of bilateral lower limb, our patient's hip, knee and ankle joint were full in range of motion and were not painful. For foot examination, there was loss of medial longitudinal arc in foot bilaterally. However, anterior transverse arch and lateral longitudinal arch were present normally. We also did some specific tests for pain in leg, and these were fulcrum test. In this test, we apply a valgus force to tibia and is performed at distal 1/3, middle and proximal 1/3 of the tibia with a moderate hand pressure as seen in this picture. The test is recorded positive when the patient expresses pain at any of the 3 sites. In our case, patient expressed pain at the proximal and the middle 1/3 junction and it was positive for right leg, however negative for left. We also did vibration testing. This test is performed by utilizing a vibrating tuning fork of 128 Hz that is placed over the identified site of pain for 5 seconds. It is performed at the distal third, middle and proximal 1/3 as well as the site of perceived pain, which was positive for right leg and negative for left leg in our patient. We also did vertical single hop test. In this, the patient was instructed to perform vertical hopping 10 repetitions with a maximum effort, and a positive vertical test is noted in 2 ways: decreasing height over the 10 repetitions or increasing landing time, that is the time on the ground. Now, and the remark of increased pain scoring with hopping, which was positive for right leg as patient expressed pain and which was negative for left. We also examined for limb length discrepancy by squaring the pelvis, as it can also relate to pain in shin or lower leg in general. In this test, we have the patient stand with their feet shoulder width apart and their weight evenly distributed on both legs. To align the pelvis, we place our hands on the patient's iliac crest, the top of the hip bones, to check for any tilt or unevenness. The goal is to ensure that the pelvis is level. If the pelvis is not level, we use blocks of varying height under the shorter leg until the pelvis is squared. This means that the iliac crest is on the same level. Now we have to measure the blocks and it can indicate the limb length discrepancy. For further accuracy, we measure the length of each leg from anterior superior iliac spine to the medial malleolus, the bony prominence on the inner side of the ankle, and it can also be done in supine position. Till now, we have a case of a 26-year-old male with pain in bilateral shin, more on right side, with swelling which was on right shin. Sharp pain that activated on exercise, running, and relieved on rest with tenderness over right medial tibia. Now, pain was even at rest and is felt even on walking, that is weight bearing, and his numerical pain rating scale score was measured to be 6. There was loss of normal medial longitudinal arc in the foot bilaterally, and there was a positive fulcrum, vibration, and vertical hop test for right leg. These are the blood investigations relevant to our case, and all of which was under normal limits.
Although I said that the patient may have forgotten history of trauma, but reverse can also be true. That as minor trauma can bring the attention of the patient to a pre-existing asymptomatic lump, which very frequently happens, and then because patient always relates it to trauma, and then we think that it is a traumatic. This can happen, say, in a hydrocele. Patient may not have noticed, or a testicular mass, a breast lump, abdominal lump. So both ways the history can be deceptive.
Patient had already come to us with X-ray and MRI right leg, and other investigations like gait analysis, running analysis, and posture foot pressure analysis were done at our department. Now for X-ray, as we can see that there was a transverse focal cortical irregularity in the anterior cortex of the mid-tibial shaft with associated periosteal new bone formation. And there is interval appearance of a faint intracortical lucency along with vertical plane of the anterior tibial cortex, which is seen coalescing with the above described transverse defect, forming a multiplanar fracture. And there was no cortical aversion or separation seen. For MRI right leg, we can again appreciate that there was a fracture of anterior cortex of the right mid-tibial shaft, which appears multiplanar. And there was associated bone marrow edema in the anterior cortex with interval appearance of intramedullary bone marrow edema in the mid-tibial shaft was noted. And also a solid periosteal reaction was noted with mild subperiosteal fluid associated soft tissue edema at the site of fracture. Now, gait analysis is the systematic.
These are our images.
No sir, he had already come to us.
These are the previous.
Yes sir.
So they did not diagnose it, or they did not advise anything for this?
No sir, so the patient was referred to the empaneled hospital at PCCI, which is at National Cricket Academy, Bangalore, because he is bound to that, bound to take treatment from places like that. But he had come to us with X-ray and MRI because he was not feeling any kind of rest, or his symptoms were not getting improved. That's why he came to our department. So he had already come to us with the reports, but there were some other reports to detect the micro things that were wrong, and we will be discussing that shortly. So for gait analysis, it is the systematic study of human motion, particularly how people walk or run. It involves observing and measuring body movements, mechanics, and muscle activity to understand movement patterns. This analysis helps identify abnormalities, improve athletic performance, and prevent injuries. Now, the gait cycle, it is very crucial to understand gait cycle before understanding the reports. So the gait cycle is a sequence of movements that occur during walking. It consists of two main phases, the stance phase and the swing phase. The stance phase makes up about 60% of the gait cycle and occurs when the foot is in contact with the ground. Whereas the swing phase makes up about only 40% of the cycle and the foot is not in contact with the ground. Stance phase include 5 subphases: initial contact, when the heel strikes the ground; loading response, when the foot is flat; mid stance, when the body moves over stationary foot; terminal stance, when the heel takes off; and pre-swing, when the toes take off. Now, swing phase includes 3 sub-phases: initial swing, when the foot lifts off the ground; mid-swing, when the leg moves forward; terminal swing, when legs prepares to make contact with the ground again. And during a complete gait cycle, both feet are in contact with the ground simultaneously for about 20% of the time, which is known as double support period. And understanding the gait cycle is crucial for diagnosing and treating walking abnormalities. So here are some visuals from our gait analysis report with significant findings relevant to our case. We can observe that there is left hip flexion. So this is a report taken at mid-stance lateral view for the left side, where instant when the body center of mass is directly over the foot. And when the left hip flexes more than normal at the end of the mid-stance, as shown here, and left ankle plantar flexes more than normal at the end of the mid-stance, which was a major deviation. I would like to ask you all to focus on the left ankle plantar flexion, which is going to be also defined in other pictures. Now here we can make out that the right ankle again plantar flexes more than normal at the end of the mid-stance, which was again a major deviation. We can make out that the both left and right feet remain in plantar flexion during the mid-stance, which can also be said for the left side of mid-swing and right side. So mid-swing begins at the end of the initial swing and ends when the swinging limb is forward and the tibia is vertical. We can again observe that the left ankle plantar flexes more than normal at the end of the mid-swing, which was a major deviation. Can also be said for the right side, as right ankle plantar flexes more than normal at the end of the mid-swing, which means both right and left feet remain in plantar flexion in mid-swing and mid-stance phase both. Here is an ankle kinematic graph, and this graph indicates the kinematic data of ankle as seen on the gait analysis just now. Now the black dotted line in the middle is the neutral position of the ankle, and the green shaded area shows the normal value, how the right and left feet should go in a gait cycle. But the red line indicates the patient's right ankle and the blue one is indicated by the for left, and it shows that ankle is not dorsiflexing at all, more so on the right side, and it remains in persistent plantar flexion throughout the gait cycle, which is not normal. For knee kinematic analysis, these are the joint angle deviations in the gait cycle for knee joint. The neutral position for knee joint is at 180 degrees, which is in full extension, well known, and as you can see that the left one is more or less in the normal range, whereas the right one is showing reduced flexion during the mid-swing. This graph shows the kinematic analysis for the hip joint, where 0 is the neutral position. Both sides patient was having slightly reduced joint angle excursions, probably due to pain. Now we also performed a running analysis on a treadmill and the videos were recorded. After putting it on the system, the report was generated. As our patient was feeling significant pain during running, it was very important for us to do a running analysis with gait analysis combined. So now for running analysis, we took initial contact slides for left and right side for lateral view, and it is when instant at which the foot first makes contact with the ground. Here we can see that there is increased inclination of left tibia at initial contact, indicating overstriding, and can also be said for the right side, as there is increased inclination of right tibia at initial contact, indicating overstriding again. Now overstriding during the gait cycle occurs when the foot lands too far ahead of the body's center of mass. This often results in the tibia, that is shin bone, being angled backward at the point of initial contact with the ground, and it can lead to increased ground reaction forces on tibia and knee. Explains the pain. For postural analysis, after carefully marking all the anatomical landmarks, bony landmarks specifically needed for posture assessment, a report was generated on our system. And here is the report. So there were some angle deviations and some major deviations that I am going to read for you now. The head was at level, no deviation. There was increased right shoulder depression. There was increased pelvic drop towards the right. The trunk is vertical, where there is increased left knee valgus and increased right knee valgus, which was a minor deviation. So however, the patient would not lean on the side of pain, but this patient still was leaning on the right side of the pain. So there is a abnormality in his posture, and this shows how the foot ankle biomechanics alters the posture, since it is the basis of support for alignment in the whole body. We also conducted foot pressure analysis for static and dynamic state, and these are the pedalographic images of the feet of our patient in standing. The red area shows the heightened pressure, and the blue one shows low zones with intermittent shades ranging from red, yellow, green to blue, where red indicates the highest pressure on the ankle and blue indicates the lowest pressure, and which will be very important for our case. As this graph shows the pressure under the foot during walking. Since the foot is pronated, as there was loss of medial longitudinal arch, the foot was in pronation, and that's why the more pressure was coming on the medial aspect of the midfoot, which is not normal, and there was in the mid stance, and relatively more pressure shown by yellow on the first metatarsal bone during heel off. So our conclusion from gait, posture and running and foot pressure analysis diagnosed biomechanical faults, which were there was increased plantar flexion of left and right ankle throughout the gait cycle, there was overstriding of tibia during running, and there was overpronation of foot bilaterally. So to understand what pronation, overpronation and supination is, the knee and the ankle is in neutral pronation position when knee, ankle and foot are all aligned at mid stance with no excessive inward or outer rotation. However, under pronation or supination is when excessive outward rotation of the knee, ankle and foot at mid stance is occurring. Overpronation, which is in our case, it is when there is excessive inward rotation of the knee, ankle and foot at mid stance. This video demonstrates how overpronation of foot can lead to disturbances in ground reaction forces and thus leading to a direct stress on tibia, which can cause stress injury. Now, I would like to request Dr. Abhilasha Maharshi, Assistant Professor from the Department of Anatomy, to come and discuss about the anatomy of leg and foot relevant for our case.
Good morning, respected dignitaries, my seniors and colleagues. Now let us discuss briefly about the anatomy of the leg and foot and their applied aspect with respect to the case being discussed. The leg part of the lower limb, it extends from the knee joint to the ankle joint. It consists of two bones, tibia and fibula. Tibia being the medial and the larger bone which is involved in the weight bearing. It consists of the proximal end, distal end and a shaft. The proximal end is the expanded end of the tibia. It consists of medial and the lateral condyle and anterior tibial tuberosity. The lower distal end is narrow and it consists of a medial projection which is known as medial malleolus. The inferior surface of the distal end is concave. It articulates with the superior surface of the body of talus to form the ankle joint. Then the shaft of the tibia is cylindrical in shape. It consists of interior border, medial and lateral border. Interior border is sharp and subcutaneous and it is known as the shin of tibia. And it has three surfaces, medial surface, lateral surface and posterior surface. Medial surface is subcutaneous throughout except over the upper part where it gives attachment from before backwards to sartorius, glacialis and semitendinosus muscle. The proximal end of the tibia, the superior surface of the proximal end of the tibia is known as the tibial plateau. It consists of the articular surface of the medial and the lateral condyle and the intercondylar area which is present in between them. These articular surface articulate with the medial and the lateral condyle of the femur, and intercondylar area, it bears intercondylar eminence which gives attachment to the anterior and posterior cruciate ligament and anterior and posterior horn of menisci. Now compartments of the leg. The deep fascia of the leg sends anterior and posterior intermuscular septum which gets attached to the borders of fibula and is introduced membrane between the tibia and fibula which divides the leg into three compartments. There is interior compartment, lateral compartment and posterior compartment. The muscles of the interior compartment, they performs the common action of dorsiflexion of the foot. The muscles of the lateral compartment, they performs the common action of eversion of the foot. The muscles of the posterior compartment, they performs the common action of plantar flexion of the foot. In addition to this, the tibialis anterior and tibialis posterior muscle, they perform the action of inversion of the foot. Peroneus muscle of the interior compartment, it performs the eversion of the foot, and the soleus and gastrocnemius muscles helps in the walking and running, acting as the bottom gear and top gear muscle. Now, the tibia is the most common long bone that undergoes fracture. It mostly because it is involved in the weight bearing. It is involved, there is direct blow to the lower end of the tibia because of the shock absorption. And also it is one of the most common bones that undergoes stress fracture. Mostly the site involved is distal 1/3 or the middle 1/3. More so distal 1/3 because it is narrower, it has thinner cortical plates, it has less bone density, and also there is precarious blood supply to the distal 1/3. There are only few perosteal arteries that supply the distal 1/3 which may lead to delay in the union or non-union of the fractures of the foot. Arches of the foot. Foot is the most evolved part of the human body. The skeletal architecture of the foot is in the form of arches. These arches perform the function of the weight distribution, shock absorption, propulsion of the body forward, and protection of the structures that are present in the sole of the foot because of the concavity of the plantar surface of the sole. There are two longitudinal arches of the foot, medial and the lateral longitudinal arch, and two transverse arches, anterior and posterior transverse arch. Medial longitudinal arch, it extends from the medial half of the calcaneum, talus, navicular, cuneiform and first three metatarsals. Lateral longitudinal arch extends from lateral half of the calcaneum, then cuboid and fourth and fifth metatarsals. In this transverse arch, it runs in the coronal plane. The anterior transverse arch extends from the head of the metatarsals, and the posterior transverse arch, it extends from the base of the metatarsals and involve cuneiform and cuboid. Now, as the case reported with the flattened medial longitudinal arch, let us concentrate on the medial longitudinal arch. The factors maintaining the medial longitudinal arch can be understood with the example of the stone bridge. The highest point of the medial longitudinal arch is formed by the superior surface of the talus. It is known as summit. Now, the summit is held in position by the sling action, which involves the action of the tibialis anterior muscle, tibialis posterior muscles, and the medial ligaments of the ankle joint, like the superficial fibers of the deltoid. Then staples are the intersegmental ties that holds the segments of the arches together. For example, long plantar ligament, short plantar ligament, and slips of the tibialis posterior, they holds the inferior edge of the bones together. Then we have tie beam that attaches the anterior end of the arch to the posterior end. The function of the tie beam here is performed by, mainly in both the arches, it is performed by the plantar aponeurosis and also by the flexor digitorum longus, flexor hallucis longus, and other intrinsic muscles of the foot. Then the most important factor is shape of the bone. The talus here is the keystone, the central bone is there. Now this articular surface of the talus is in the form of a wedge. Now this wedge, it fits into the mortise formed by the formed by the tibia and the fibula, and it locks the ankle joint, stabilizes the ankle joint, and also helps in the stabilization of the arches of the foot. So these are the factors that maintains the medial longitudinal arches. These are some common foot arch deformities. The current patient, it reported with the pes flavus, that is the flat feet. It may occur either due to the collapse of the longitudinal arch, or it may occur because of the failure of formation of the arches. The common causes are arthritis or damage to the factors that we have discussed, like damage to the tendon of tibialis posterior or the spring ligament or plantar aponeurosis, and it may occur as a congenital deformity. Then overpronation. Pronation is basically the inward rolling of the foot. It involves three movements. There is eversion, dorsiflexion, and there is abduction of the foot. Overpronation is basically excessive inward rolling of the foot. Forefoot rolls over the calcaneum and talus. The causes of the overpronation, it includes flat feet, which is reported in the case, flattening of the arches of the foot. It may occur due to the weakening of the intrinsic muscles of the sole and muscles of the calf, either weakening or tightening of the muscles of the calf. And it may also occur because of the poor walking cycle or the poor biomechanics. So this is all from the anatomy side. Now I invite Dr. Divya Joshi to please come and discuss about the pathophysiology of the stress fracture.
Good morning, respected dignitaries, my seniors and my colleagues. I am here to discuss about the pathophysiology of stress fracture. So, let us know what causes stress fracture. Stress fractures are caused by the repetitive application of a greater amount of force than the bones of your feet and lower legs normally bear. What happens is, when bone is subjected to repetitive loading, micro cracks may occur within the cement lines. Then the normal remodeling process repairs these cracks. So, if the bone continues to take stress, then crack propagation occurs. When this crack propagation outstrips the repair, then a painful stress fracture occurs. Here, the osteoblastic activity lags behind the osteoblastic activity. So, some examples where stress fracture occurs are military recruitment training programs and get fit quickly training programs. Now, let us have a look over this picture, which is showing the propagation of stress fracture. First, it starts with the silent stress reaction, where there is an accumulation of micro damage. Then there is stress reaction, which includes the crack initiations, and then ultimately the stress fracture occurs. Here is the law which is important in this part. It is Wolff's law, which was proposed by the German anatomist Wolff. It states that the bone will adapt to the degree of mechanical loading such that an increase in loading with the strengthening the bone and decrease in stress will causes weakening of the bone. The duration, magnitude and rate of forces applied to the bone dictate how the integrity of the bone is altered. So with this picture, we can understand that when stress, load or compression goes over the bone starts with the process of bone remodeling, in which osteoclast removes the bone, that is the process of resorption starts, and osteoblast will help with the process of bone formation, and ultimately the bone is adapted to the stress. Thus, this Wolff's law helps us to understand the integrity of our bones and also helps in strengthening the bone. Thank you. Now I would like Dr. Meghna to continue with the management part.
Discussing the management of our case. For that, as stress fracture usually heals in 6 to 8 weeks with rest and non-weight bearing, which is well established and known to all. But in our patient who had already taken rest for almost 3 months, it was showing a delayed healing since the symptoms still persisted. Ultimately, our patient would need surgical intervention and intensive rehabilitation, which would take a few months, and for a young sports person who is in his budding phase of career, would limit his chances of getting into national cricket team. As by treating the root cause of the stress on tibia, during preventive rehabilitation in this case, patient could be reintegrated to sports without the need of surgical intervention. So, our faulty biomechanics well established were overpronation of foot, and there was excessive plantar flexion of ankle during gait and running. These are the micro disturbances in gait. We all know about major abnormalities and gait patterns, but we have never thought about micro disturbances that can also lead to a lot of conditions and can be solved with simple measures. So our patient was undergoing routine physical activity during the management period and was not asked to rest because he has already taken enough rest and he wanted to practice for his upcoming event. So we asked the patient to be on a graded physical activity depending on the stress of the fracture. We continued with non-pharmacological and pharmacological management together, in hand. We advised our patient for low intensity pulse ultrasound therapy. We prescribed our patient of Lipus, which is also reported to improve bone mineral density and was given at a 1 megahertz burst waveform frequency and at an intensity of 0.8 milliwatt per centimeter square, 8 minutes per day, and 21 sessions were given. Now, it is said to stimulate bone growth as it can jumpstart the healing process by stimulating bone growth and preventing further breakdown at the fracture. It also enhances calcium incorporation as it encourages the incorporation of calcium into the bone, which is crucial for bone strength and healing. We also prescribed our patient ESWT, which is extracorporeal shockwave therapy, and it is a non-invasive treatment that uses shockwave to promote healing in various musculoskeletal conditions, including stress fractures. It was prescribed at a frequency of 5 Hz, power level of 60 millijoules, and number of shocks for treatment to be given were 1000 shocks. 3 sessions alternate day for a week was given, and it helps in stimulating bone healing as it has an osteogenic effect, meaning it stimulates the activity of osteoblast, which is needed for the fracture healing, the cells responsible for bone formation. It also accelerates the healing process of fracture by increasing the blood flow in that area, which helps deliver essential nutrients and oxygen to the damaged tissue, promoting faster recovery. And it also helps in reducing pain as it can help diminish or discomfort by desensitizing the nerve endings and reducing the inflammation. With the help of a dietitian, a balanced diet rich in vitamin D, calcium, magnesium and phosphorus, which are very essential for bone health, was prescribed to our patient to maintain good bone health. Also, biomechanical correction, which is the major correction that needs to be done in our case. We prescribed a bilateral medial wedge insole of 1 centimeter to be worn at all times, especially during high impact activities like running and jumping, and to improve the plantar flexion that we established during the gait cycle, which was abnormal finding in our patient. We advise for ankle dorsiflexor strengthening and calf stretching. A medial wedge insole is a type of shoe insert specially designed to correct foot alignment issues, particularly overpronation. Overpronation occurs when the foot rolls inwards and excessively while walking or running, which can lead to various problems such as knee pain, hip pain, and lower back pain, leg pain. Key benefits of medial wedge insole include correcting foot alignment by providing support to the inner side of the foot. These insoles help to stabilize the foot and prevent it from rolling inward excessively. It also helps in reducing pain as it can be associated with conditions with flat feet, knock knees and certain types of arthritis. It also helps in improving posture as proper foot alignment can lead to better overall posture and reduce strain on other parts. A proper exercise program was curated for our patient, focusing on calf and ankle dorsiflexors and to reintegrate him back to sports. Side by side, we had also prescribed him tablet paracetamol 1000 mg SOS for pain and tablet alendronate sodium 35 mg once weekly for 3 months to prevent the recurrence of stress fracture. As alendronate causes inhibition of osteoclastic activity and thus reducing bone resorption and helps in increasing and maintaining bone density, making bones less susceptible to fractures. By reducing bone turnover, it helps in maintaining structural integrity of bone that helps in preventing stress fractures. And also calcium and vitamin D3 supplements were advised for nutritional requirement of bone health. Response in our patient, there was significant pain relief in patient in 4 weeks and is now reintegrated back to sports. As you can see that the numerical pain rating score was 6 and now it has come down to 1 to 2 and there is no pain and he can run and practice his sports activities without any discomfort. For MRI post-management, comparing with the pre-management MRI, there was progression in the degree of bone healing in the stress fracture of the anterior cortex of the right mid-tibial shaft and there was stable appearance of the bone marrow edema in the anterior cortex with resolution of the intramedullary bone marrow edema in the mid-tibial shaft on the present study. There was also reduction in the degree of prior noted subperiosteal fluid and associated soft tissue edema at the site of fracture. It is also said that alendronate can also help in reducing the bone marrow edema. However, there is not much evidence, but as seen in our patient, it did really help. So, next time you have a knee pain, back pain, or ankle, foot pain, don't just think that there could be something big. It could also be something very small and can be treated very easily. So, preventive rehabilitation is as important as the interventions. Now I would like to request Dr. Sonu Singh, Professor from the Department of Physical Medicine and Rehabilitation, to conclude our case.
Thank you. We have seen so much about stress fracture. Stress fracture, it accounts for almost 1 to 20% of all the sports injuries, but 80% of the fracture occurring in lower extremity. These are quite common in impulsive high load activities like running, aerobic exercise and therefore require expertise in diagnosis and management. Recovery time generally varies from 2 to 8 weeks depending on the location, and management consists of pain, management of pain, relative rest, optimal loading, and optimal rehabilitation include consideration of entire musculoskeletal system. Like in our case, we as we corrected his foot overpronation and his stress fracture recovers. I'll pass on. These are few of the new therapies. Those are available like bone morphogenic protein, growth hormones, recombinant parathyroid hormone, low intensity pulse wave in that we have used, magnetic application of magnetic field and regenerative therapy, and like platelet rich plasma therapy that we are using routinely. And the criteria for return to sports, these are few of the laid down criteria for return to sports include absence of pain at the site affected, especially during sports movement. Second, absence of symptoms during pain provocation test, absence of abnormalities in imaging examination, and comprehension by patient, trainer and technical team of the sports regarding the risk factor and condition that led to the injury, and so the correction can be made so as to prevent recurrence and recurrence of injuries. The gradual definitive return to sports activity should be started after the patient has been free from pain for 10 to 14 days, like in our case, with 10% increase in training time, training intensity per week. Biomechanical factors predisposed towards such factors, like in this case overpronation, need to be monitored and corrected through the correct understanding of the sports movement, equipment orthosis, training surface and all other factors that may involve in sports practice. With this I conclude the case. Thank you. Thank you.